I want to just hit upon these devices and one of the options that is available to us now. These all obviously have in common that they have an interbody device and some type of adjuvant fixation, most often pedicle screws. The goal for all of these techniques, and no one can choose one or the other, we have no good evidence for which one is best, as Dr. Alon said. The goal is obviously the same: treat the patient's disease within the confines of either your own experience and or available technology. For future trends for interbody, these are just some of the options out there. What's the best material? Is it trabecular metal, PEEK, cadaver bone, biologics? What is the role for biologics? Gentlemen over there as well, what's the role for expandable cages, deployable mesh grafts, and what's the best technique? ALIF, lateral, TLIF, et cetera. The techniques are continuing to evolve, and the instrumentation is changing, and these are all things that we need to be aware of as these techniques go on, but they're all excellent techniques. What are the future trends for pedicle screws? Minimally invasive, I think, is here, obviously. Navigation assistance, percutaneous placement, all here, but need to be developed and need to continue to prove that they are as good or perhaps better than open techniques. 3D robotic assistance, we heard this morning from Dr. Dubois, as well as we'll hear later in the week. I believe on Saturday there's a talk on 3D robotic assistance, coated screws, hydroxyapatite, collagen, and chondroitin sulfate are all three materials. What is their role? What's the role for, expandable pedicle screws? And again, what are the role for biologic? Because it's late in the afternoon and warm, I figured I would throw out something a bit provocative rather than just reviewing what we've heard. Because they've done an excellent job, there's no reason to go through that. Do we need an alternative to pedicle screws in interbody fusion specifically? We know that pedicle screws carry a risk of neural injury. There's operative time. There's fluoroscopic exposure to the patient and particularly to the surgeon over a cumulative career. Risk of malplacement, osteoporotic bone. What's the role of pedicle screws in osteoporotic bone? And the incidence of durotomy. Is the picture on your left equivalent to the picture on your right, assuming there's an interbody in the one on the right? I couldn't find one, I apologize. So this last 5-6 minutes, I just wanted to touch upon interspinous fusion as a potential for interbody fixation. The rationale is this is not dynamic stabilization, this is not X-stop, this is interspinous fusion. It's using a standard, familiar midline approach. There's excellent visualization. It is muscle sparing compared to an open TLIF, not obviously compared to the minimally invasive percutaneous techniques. You're generally not burning any bridges in terms of still having the pedicle screws available to you. And there is a small body, but there's increasing literature support. There is evidence back to the 50s, probably even before that, that there is some evidence that lumbar interspinous fusion has a role. There's a paper that will be presented on Friday, and then there's a paper from the Journal of Korean Neurological Surgery discussing posterior interspinous diffusion fusion devices for one-level fusion in degenerative lumbar spine. And that study discusses the safety in terms of patient results being improved in terms of pain relief, decreased blood loss, decreased operative time, decreased fluoro time. And there is a claim in that paper regarding adjacent segment disease. I think it's a bit early. That's a one-year follow-up study. It's a bit early to discuss adjacent segment disease, but it is intriguing and does bear further discussion. In terms of the biomechanics, there are several biomechanical studies demonstrating that interspinous fixation with interbody devices have similar resistance in flexion and extension, less so, obviously, in lateral bending and axial rotation. There is some evidence as well of increased load sharing with the graft, which may actually augment fusion. This is another study. ALIF plus interspinous fusion is equivalent to ALIF plus bilateral pedicle screw rods, and people are using interspinous fusion devices as adjuvant to ALIF. They're using them as adjuvant to lateral lift rather than turning the patient and doing a posterior fusion. You can keep the patient on their side and place an interspinous device as a perfectly valid option. My technique that I've been using now for almost 4 years, and this is data that's not yet published, but it was submitted for publication, is using it as an interbody fusion device via a modified TLIF approach. So I do a discectomy on the symptomatic side. And through that discectomy in a mildly lateralized, but obviously bearing in mind the facet should not be disrupted substantially, you do a discectomy, place a TLIF cage from a unilateral approach, and then fix the spinous processes with an interspinous fixation device. And I generally will decorticate the contralateral side and do a laminar and a lateral facet fusion. These are some of the devices available. The bottom line here is that we are clearly finding that we are reducing OR time, decreasing blood loss, and decreasing fluoroscopic exposure. But just like with many of our techniques, we need true comparison studies, probably to the gold standard, pedicle screw fixation, particularly with regard to some of the downsides of interspinous fixation, focal kyphosis at the level of the fusion and what effect that has on interbody cages. I'll get to that in a moment, and the potential for spinous process fractures. Actually, as you know, the junction between the lamina and the spinous process is very solid cortical bone. Even in an old osteoporotic patient, that bone is relatively strong. Most of my results are based on in red, the single level decompression with an interbody device with an interspinous fixation. I have 74 consecutive patients from October 2010 to November 2012, all retrospectively reviewed, average age 56. Though again, when I first started, my indication was for the older patient in whom I would not do an open procedure, and I've decreased the age a bit simply because the results are demonstrating good results. The length of stay is coming down as well. I don't really think there's a significant learning curve, although the results are better, but it is something that over time, I think you find that you don't need to keep the patient in the hospital as long as you might have thought, certainly with open techniques. The EBL, my mean was 261. Fluoro time, 35 seconds. Now most of my cases are 12 to 15 seconds. Durotomy in 12% of the patients, which is high, does compare with open TLIF, and I think, again, although I said no learning curve, I think a lot of the durotomies were in the earlier cases and in some of the redo cases. I had one spinous fracture, a spinous process fracture in a morbidly obese female who fell out of bed 2 weeks after surgery. There wasn't a device failure, that was an osteoporotic fracture in a woman who fell. And the real concern is the intervertebral body graft displacement. Because you are not able to compress, or most of the cases you're not able to compress, there are some now compression devices, but there were 6 patients in that series, an 8% rate, which I think is overly high, but I've begun to correct for that by placing the cage more anteriorly and using lordotic cages. The misplaced screw is obviously 0. In my hands, anytime a lumbar fusion is being considered, I would consider an interspinous device, and obviously there are significant, I won't go through the indications because they're all the indications for fusion, but the significant contraindications are an isthmic spondylolisthesis. There's nothing to affix. You can't use that, obviously. A prior laminectomy where you no longer have a spinous process, or an inadequate S1 spinous process. If you have true instability, particularly any spondylolisthesis greater than 1, I would not consider it. Severe osteoporosis for obvious reasons, and anything, a long segment, any scoliosis correction, obviously, there's no role for this type of device here. I just have a few cases just to give you the concept of what I've been doing. This is a 52-year-old woman, L5S1, one-level degenerative disc. She received a left-sided interbody device with an interspinous fusion, and 3 months after surgery, she was in Aruba windsurfing. This is a 72-year-old gentleman with a L4-5 grade 1 spondylolisthesis, no significant motion on flexion extension, back pain greater than leg pain, also with a one-level interbody device with an interspinous fixation. There is a partial reduction of that spondylolisthetic level. This is, I think, a very good case for this. This woman had a prior minimally invasive TLIF, L5S1, came to me from a partner, a colleague of mine, with a massive disc herniation at L4-5, had a discectomy and an interbody interspinous fusion segment above. This is a case that I don't think is going to work long term. I think there's already some this is 3 months out, there's already some settling of that, some subsidence of that interbody graft, and I think the forces may be too great to handle, but at the moment, clinically, she's doing well, but I'm obviously concerned about this lady. This is one that I just wanted to show because of the severe rheumatoid arthritic woman who's prednisone dependent, who is, has cardiac issues as well, certainly could not stand in any way an open procedure, and she's got severe motor changes at L4-5, a slip at L3-4. She had this interbody interspinous fixation. The perioperative film or the intraoperative film is in the middle, and the 3-month film is on the right side. She actually subsided a bit, which is to her advantage because she's actually corrected some of her curvature, which is actually a good thing. You can see that the interspinous devices are closer on the right-sided film. And clinically, again, no back pain, not no, but much less back pain and no radicular pain. This is the complication. If this is the intraoperative film, she's got a cage that you can see there's anterior collapse. This is asking to be spit out posteriorly, and now that I've been doing it, this obviously wouldn't work. So this is a straight cage, not a lordotic cage. And again, with anterior collapse, you do need to be careful. She did go on to spit that graft. She had significant leg pain and no permanent deficit. She did have numbness and leg pain. She had no weakness. We took out that graft, put in a larger graft, and did pedicle screw fixation on her. So that's what I mean by burning no bridges. There's absolutely other things you can do in these cases. This one, just to show a combination, this is an L4-5 isthmic spondylolisthesis and an L5-S1 degenerative disc. She had symptoms referable to both levels and significant back pain. The L4-5 I fixed with standard pedicle screws. These are peak rods, but she had standard pedicle screws with an interbody, and then because of the L5-S1 symptoms, the facet changes as well as the discogenic changes, I placed a standalone interspinous device at that level in combination. She is only 6 weeks out, but again, her back pain is down from 8 out of 10 to 4 out of 10, and she has no radicular symptoms at this point. I think one of my concerns is that the device is so easy to place that there's a concern that people would be overusing it, or even in my own practice, you might say, well, you're doing a discectomy, why don't you just put an interbody graft in and put an interspinous clamp on? And I think that's wrong. I think you need to view it as a fusion device, an option for fusion, and it's got, again, the same indications as, in my hands, as anybody who would otherwise have an interbody fusion by any approach. This is just the last slide just to show that there is evidence of fusion. She's got posteriorly here at L4-5, and between the spinous processes of L4 and L5, there's definitely growth of bone. So it is a fusion, and it is, again, I'm not arguing the indications for fusion, just that the interbody and interspinous technique is a viable alternative. We need a lot more information. Again, there's a talk this week, and this is to be submitted for publication as well. With all of our technologies, we need more information, but this is something to consider as an adjunct to ALIF and lateral lifts rather than pedicle screw fixation. I think that's a home run. That's very easy, and again, biomechanically, there is some evidence. To do an interbody with an interspinous is something that I and many others are looking into pretty significantly as a potential option, without any pedicle screw misplacement, zero, and without any significant fluoroscopic exposure to the patient or the surgeon. Thank you.